This is Brady Blackburn with the North Carolina Medical Journal. I'm here with Philip Cooper, the Chief Change Agent at Operation Gateway, an Asheville-based organization that works to decrease recidivism by addressing the social determinants of health of returning citizens. Philip, thank you so much for joining us today. To get us started, could you introduce yourself and tell me about Operation Gateway and how you do your work to decrease recidivism?
Yeah, glad to be here. Thank you for this opportunity to be a voice of the people, to be a voice for those who are directly impacted, trying to make a change by way of leveraging their lived experience. And so, my name is Philip Cooper. They call me Coop. I am the founder and chief change agent at Operation Gateway Incorporated, which is 100% of our staff at this time are formerly incarcerated people who are now in recovery. And as far as like how we do the work to decrease recidivism, we're all about addressing the person with a holistic approach. And we love our friends in the public health space because they always talk about social determinants of health, social drivers of health. What are the root causes? And so for us, that looks like providing whole person services, not just siloed into one sector, but we're more like the navigators of the ecosystem, the coordinators of the ecosystem when we look at reentry. So that's food, that's transportation, that's healthcare, that's education, that's economic stability, whether it's getting them a job or helping them know how to budget their money, reconnecting with their families, social and community context, getting them connected with building, social capital by way of faith communities or recovery communities, because that social capital is everything. And then looking at like neighborhood and built environment, what types of neighborhoods, what types of reentry programs that they need when they first come out of prison so that they can have a healthy reintegration into society.
Absolutely. So, what led you to this line of work and how did you come to found Operation Gateway?
Well, as I mentioned earlier, leveraging lived experience. So I'm formerly incarcerated myself. I gave up the high cost of low living on January the 16th, 2009, which is my sobriety date. But I went into prison. Well, my sentence started in like 2007. So I did a little over 3 years in prison. And while I was in prison, a light came on. I had a spiritual awakening. I rededicated my life to Christ. I seen that I had more potential than what I was displaying, right? There was a reinvention and I seen the power of peer support. I actually worked as a peer support while I was incarcerated. And so when I came home and I got into the field, I worked for the agencies, behavioral health agencies, worked for government jobs. And then what I seen was that the issues that needed to be addressed needed to be directly addressed. They didn't need to get put on the back burner. And for me to be able to truly address the disparities that I was experiencing myself, then I seen other people experiencing, it had to come from the grassroots level because we can't expect people who work in the bureaucracy to do certain things. That is an unrealistic expectation. And so I seen like it's going to take me doing this work from outside and partnering with those on the inside.
So I feel like I'm already getting a sense for this with the passion you're bringing to talking about the work you do, but you're Operation Gateway's Chief Change Agent, and I'm really curious to hear from you what the meaning is behind that title and how it reflects the way you approach your work.
Well, I gotta take it back. I take you back to when I got out of prison. I was going to AB Tech Community College, my alma mater. I was in the Human Services Technologies program, which is an amazing program, and I'm so excited that our state have passed legislation to where people like myself who completed that amazing program, the Human Services program, are now considered as qualified professionals in the mental health and substance use space. And so, when I was in my schooling, right, at AB Tech Community College, I was taking a class, Intro to Human Services, and I heard the name Change Agent talking about human services professionals, and I grabbed a hold of that thing quick, real quick. You hear me? And so started going by Change Agent ever since then, and still do, man. It's a movement, it's a way of life, right? And so later on in life, getting speaking engagements and everything like that. I forget who it was, but somebody called me Change Agent Cooper. It was my boy Mike. My boy Mike called me Change Agent Cooper. I adopted that, started going by Change Agent Cooper because I was just known for, speaking truth to power, showing up in spaces. And so that Change Agent has been tied to me strongly over the past about 7, 8 years, fam. And so whenever we started this organization, I wanted us to be seen not like with necessarily a hierarchical structure, though that is needed within the infrastructure of a nonprofit. I still wanted us to see each other as change agents.
Absolutely. Thank you for that. So another term that I've read about and heard you talk about that I'm curious to hear more on is inReach. And I'm curious if you could tell me a little bit about inReach, what that term refers to, and what types of inReach work you
Yeah.
do at Operation Gateway.
Well, what I'll tell you is in-reach is the best practice, right? So I started doing this reentry work pro bono. It was never a job. It was me doing the work pro bono. And when I was doing the work, but then I didn't know, like I didn't have a strategy. All I knew was help, and I was helping people who was getting out. So I wasn't getting connected to them until they was getting out. Then somebody from the community, faith community, or so on and so forth, would then hit me up and be like, "Hey, I know somebody that needs some help," right? And so I was getting them like that. But then once I got into the field, I started getting connected on LinkedIn. And so shout out to LinkedIn, by the way. Like if you're a professional, it don't even matter what sector you in. Any professional need to have a LinkedIn account, right? And so I was on there. I started getting connected from speaking engagements I was doing, following different people. And I had connected with in Washington D.C. They have a mayor's office on returning citizen affairs, and I had connected with a guy named Lamont Carey at the time, and he was just giving me the game and giving me pointers on how to do reentry, and he basically provided mentoring for me. And shout out to him. I'm gonna have to reach out to him on LinkedIn. But one of the things he told me back then, this was like the year 2018 or 2019. He was like, bro, if you're not connected with them until they get out, then you're not properly serving them. You got to connect with them before they get out to assess their needs. And I didn't know that, but then when he said it, it makes so much sense. So enrich is when we connect with people before they get out of prison, connect with people before they get out of a treatment center. You did to assess their needs, establish rapport, and create an individualized reentry plan. Because if we're talking about holistic reentry, we're talking about healthcare, we're talking about budgeting, we're talking about driver's license restoration, we're talking about family reunification. We need to be putting together a plan before you get out, because once you get out, you got so many options. And one of the things that we do see happens to a lot of our people that we don't get to connect with while they're on the inside. By the time they get out, they got so many options. They got something that we like to call analysis paralysis. And they got so much going on to where they don't know what to do, and they oftentimes freeze up. Or guess what else? Uh-oh. They oftentimes will revert to something else to get the edge off, which was typically an illicit substance. The best practice, though, Brady, would be us being able to go inside the prison, offer a group, some type of curriculum. But we're not able to do that right now. I'll say it's mostly because the prisons are short staffed, and the staffing impacts what programs can come inside the prisons. And so in-reach is not being done the way that it's supposed to be done right now. And I would say it's due to staffing. And I can empathize with the prison staff who are working, because right now, after the budget cuts, I'm wearing multiple hats myself. And I see how staffing can impact the overall operation.
So I actually, before we move on, I want to ask a quick follow-up question there because you've mentioned budget cuts and a staffing shortage, both on it sounds like the end of the prisons themselves, but also on the end of organizations like yours that are working to do this kind of in-reach work. So you're seeing this impact in-reach efforts and make it so they're not happening the way that you would like to see them happening.
That's correct.
Gotcha. So I actually want to ask a little bit more about that later on when we talk about Medicaid. But for now, I want to take a step back and talk about just incarceration, behavioral health in North Carolina in general. Could you give me a quick snapshot of where North Carolina stands in your eyes in terms of incarceration, especially for marginalized populations?
Well, I'll say, that black people are overrepresented in the prison population nationwide, right? There's that. Also, when we look at like the United States of America, we incarcerate more people than the rest of the world. And so incarceration, mass incarceration, public health crisis. It's a public health crisis that's impacting more than just the incarcerated person, but it also impacts the family. Like if you refer to the Healthy 2030 report, you see when they talk about improving outcomes, for marginalized, they mention two things: out of school expensions and incarceration rates, because they correlate. And so, if we're looking at incarceration and we're understanding that mass incarceration is a public health crisis, we have to look at alternatives to incarceration. And so, what are we doing in North Carolina as we talk about behavioral health, as we talk about prisons? I'll say there's some great work that's starting to cook up. I'm not gonna just say that we suck. I'm gonna say there's some things that are cooking up right now. I know they got these new justice reentry teams, like with the management care organizations like Via Health, Trillium. Alliance, Partners Behavioral Health, they have these justice reentry teams in which the management care organizations are working closely with the social workers, right, to get referrals for folks who have severe mental illness or violent crimes, right? But it's still dependent upon the referral from the social workers, fam. And that's the hard part. It's like now we're expecting the success of this person is dependent upon whether or not a person puts in a referral or not. And so that has been challenging. And I believe that we're looking to make some improvements with that. That's just how they created it from the beginning. So that's why I say we cooking up, and I believe that they'll be learning from what needs to happen based off of what's going on now to make some improvements. The other thing too that I would say in North Carolina is that they recently implemented these forensic assertive community treatment teams. I don't know a ton about it. I just seen that email that went out in Hot Topics from Kelly Crosby, and I'm excited about that as well because you have a team and you have that lived experience baked in. I love it when they honor lived experience because lived experience plays a major role in instilling hope to people who are hopeless. So on the behavioral health side, where there's room for improvements, if you're asking me, I would say we need to have more access. People with lived experience need to have more access to the people while they're on the other side. I believe there needs to be more communication between the social workers, the MCOs, and the community based organizations. I believe that ecosystem requires a communication amongst each other, right? Especially those who are going to be providing boots, what we call boots on the ground services for said individual. We're going to be the one to make sure that they get to the appointment that the people at the management care organization schedule. We're the ones that's going to take them to the appointment. We're the ones that's going to take them to the grocery store. We're the ones that's going to potentially take them to a 12-step meeting or a faith-based meeting. We're the ones that have focus groups for the returning citizens to come to in person or virtual for people that have transportation as a barrier. And so having a community-based organizations heavily involved in the behavioral health work for the returning citizens should be priority because we're the ones that's helping navigate the resources when they come home. In years past, people used to give them a sheet of paper and say, okay, you go do this, or give them a guide and say, do this, call this person, call that person. But sometimes those guides and those lists be outdated, right? And that's why we got to lean on community-based organizations, and that's why I love my public health people so much because they put the value on the community health workers because they understand the role that we play. Community health workers, it is a evidence-based practice. We serve as links, liaisons, and intermediaries between the people and the resources. And when you look at the peer support specialist credential, it is under the community health worker umbrella. The peer support specialist is more of a community health worker that focuses on behavioral health.
Absolutely. We actually just finished, we just recently conducted an interview with Honey Estrada, who's the president of the North Carolina Community Health Workers
Yeah.
Association. And there's a lot of parallels between what she spoke about and what you're talking about here, especially when it comes to coordination between all of these sometimes disjointed services, making sure that they can work together, run smoothly, and how especially community health workers can be that glue, working between something like a direct care provider, community
Yeah.
based organization, individual who needs the services.
Yeah, we navigate it, man. Cause like even with the federal qualified health centers, I'm grateful for them, and I'm grateful for the leadership of Dr. Evan Ashkin, who started the NC Fit program, North Carolina Formerly Incarcerated Transition Program, and we host the program site. So Operation Gateway, we are the program site of NC Fit, the only one when you pass Charlotte, we're the only one that exists. And so, shout out to Dr. Ashkin and that model because they're at least able to prioritize getting people streamlined connections and appointments.
At the North Carolina Institute of Medicine and the North Carolina Medical Journal, we're taking a look at all of the different health indicators specified in Healthy North Carolina 2030, one of which is incarceration rate, to mark the halfway point in this decade. The Healthy North Carolina process centered around addressing the social determinants of health. How does addressing the full spectrum of health related needs help with incarceration and recidivism?
Well, I'll tell you from my lived experience, I self medicated a condition that I didn't get treatment for that led to criminogenic activities. And so we've done a lot in the harm reduction space in the state of North Carolina. I feel that in 2026, we need to do more in the prevention space, the relapse prevention space, the prevention space for youth, but prevention. We need to talk about prevention way more. And so, as we look at how that addresses the full spectrum of health needs, A person who is not mentally stable is not going to consistently partake into any kind of service because their life is unstable. And so as we look at social determinants of health and we look at access to health, one of the things I love to do when I have speaking engagements is I'll have the crowd chant back to me, mental health is health, right? And so for us, if we're looking to decrease recidivism, we have to be ready to deal with the trauma that the people experience whenever they're in prison and the trauma that they experience pre-incarceration. Because guess what? A lot of people have, I don't know if you ever heard of it, but the adverse childhood experiences, right? When you look at people's adverse childhood experiences, that also has a correlation with criminogenic activities, my brother. And so as we look at addressing that health piece, we got to take into mind that mental health piece, and we got to do it pre-release. We got to address stigma. We got to address stigma because when you look at marginalized communities, especially in black and brown communities, nobody wants to talk about mental health. And matter of fact, is you better not talk about what goes on in this house because what goes on in this house stays in this house. And see, that has paralyzed and been like a generational curse for people. And that's why you see so many people self-medicating that's on the drugs. And so as we look at how we can address this, with a full spectrum of health-related needs, the main one that I like to talk about is the mental health side, the behavioral health. And so, as we do that, what does that look like doing it on the inside? Having those people with lived experience, having those qualified professionals connecting with incarceration or people before they get out. Sharing stories, sharing testimonies, normalizing therapy, normalizing talking about diagnoses, because a lot of people go undiagnosed and they have conditions, or they came off meds when they was in high school or when they aged out of foster care and they never continued in their services, and the next thing you know they was living life on the wild side. And so for us to impact recidivism 100%, we got to be talking about health, and mental health is health.
Absolutely. So, to transition real quick, I do want to ask about your mission statement. You said that your mission statement recently changed.
Yeah.
Could you tell me a little bit about what changes you made to your mission statement, why you wanted to change your
Yeah.
mission statement, and what that means?
So like before I was telling you, like in the earlier part of the interview, when I was saying like I started Operation Gateway to meet the needs of prison reentry, and it was solely prison reentry because that was the ones that was getting the short end of the stick, because we have, especially in this area, amazing programs in the jails. They even had like medication, get starting people on medication for opioid use disorder while they are in the jails, man. They had a lot of great programs, but the people coming out of prison was having the hardest time. So I started an organization to meet the needs specifically of them. But then the more I done the work, the more connections I got, the more they started requesting us to do more, right? And so when we looked at who we were serving and how we were serving them, like we're getting a significant amount of referrals coming from halfway houses. We're getting referrals coming from jails, treatment centers. And so we had to revisit our mission. And the main reason why we had to revisit our mission is because when we look at recidivism, which is tracked on a 1, 3, and 5 year, somewhere around there, typically with organizations, right? Justice departments and organizations like ours, for us to truly impact recidivism and by way of what our mission was saying, addressing the social determinants of health, we got to have a residential reentry program. And we don't have a residential component. We got money, shout out to the North Carolina Department of Health and Human Services. We got money to be able to pay to pay that money to get a person into a halfway house. Because around here, houses cost anywhere between $800 to $1,000 a month is how much it costs for the returning citizen. And so we was getting this grant money, and then we pay that money to get a person into the house. Then they got to hurry up and find a job. They not worried about healthcare. They're not worried about financial literacy. They're not worried about nothing else but to hurry up and get a job so I can pay the halfway house man what I owe him so they don't kick me out. You see? And so for us to truly have reentry done the best practice way and the way that we need, we got to have a residential program. And until we got a residential program, we can't stand by that mission because we've seen a significant amount of people go back to their way of life because of housing instability. And that housing instability is preceded by what they call collateral consequences. Because you got a record, it's harder for you to get a job. So you might not be able to hurry up and go get a job that's going to avail you an opportunity to pay what it costs to live in that halfway house, pay your probation fees, your child support, buy your own food. You see what I'm saying? And so having a residential reentry program is what's needed. And that's why we changed our mission from we are decreasing recidivism by addressing the social determinants of health, because of the main one of the main determinants of health we are not sustainably addressing. Okay. The new mission statement that we got, is something that I allowed the team to have input on. You feel me? The staff, the board. It wasn't just me that was cooking up something because I was oppressed trying to save the world by myself with a board that I had recruited to help start an organization. Now, as we move forward, we got the change agents involved contributing to what the mission is. You feel me? And our new mission is together. You notice the first word we start with is together. We leverage lived experience to transform lives and reduce the stigma of recovery and reentry. That's what we do. We reduce stigma. That's what we do. And the system can't stop us. See, the system can stop us from from decreasing recidivism. The system ain't got to partner with us. They ain't got to honor and respect lived experience. They don't have to. But we can still impact stigma because we can recover out loud. We can make sure we got the resources and we can leverage our lived experience to transform lives. That's what we can do.
Absolutely. Well, thank you for explaining that. I think that that makes a lot of sense, and I know I've read in other interviews you talking about that other phrase, recovering out loud, and I can definitely see that through your mission and through the way that you're answering all of these questions. So thank you. So another important topic in healthcare right now that I want to talk about is Medicaid, with
Mm.
significant policy changes both on the immediate horizon and in recent history here in North Carolina. Two that carried implications for incarcerated people were Medicaid expansion and North Carolina's Section 1115 waiver. Could you tell me a little bit about that 1115 waiver, what it is, and how it helps support people during reentry?
Well, the biggest part that and I'm not gonna say that I'm an expert with the 1115 waiver. I will say before it passed, I went one of the funding streams that we have now. Interestingly enough, was it was started. The innovation started while I was at one of those hearings where they have public comment, and I went up there because they was talking about this portion of the 1115 waiver that I'm about to discuss. So the thing that's excited is with the 1115 waivers, they start to engage with people pre-release as far as it relates to the services. And we all about in reach and we all about pre-release. But one of the things that I said back then when I was in public comment was like, you can't expect a short staff prison to do one more thing. Like now, let's be realistic about what's going on because oftentimes people that come up with these policies and everything, they're not close to the problem. And those who are closest to the problem are closest to the solution, right? And so I'm optimistic about what can be done with getting people connected before they get out. Everything that we can connect them with before they get out is a big win, if you ask me. Come on, man, because pre-release engagement is what's needed. Because by the time that they get out, they got all these options, and we don't want them to suffer from analysis paralysis, right? And so, with that 1115 waiver and that Medicaid piece, that helps the people be able to get the treatment, the health care, and all the things that they need. Because Medicaid does, but to be honest, fam, Medicaid do better than insurance. Like I done seen folks that had better cover, I mean better services and everything when they had Medicaid than they did once they got a job and had insurance. And so this is amazing for that 1115 waiver for people that's trying to get their life together so that they can have their health taken care of because health is important. And I gotta continue to say that mental health is health.
Absolutely. So, in a similar vein, Healthy Opportunities Pilot HOP is another program that's been in the news. Also has an uncertain funding future. You've spoken about HOP and how it also helps support returning citizens. Could you tell me a little bit about that? How the Healthy Opportunities pilots have supported housing, transportation, and those behavioral health needs among this population?
Man, Hop was amazing, fam. I have people that work for Operation Gateway now who got released from prison less than, 3 years ago. Like we got one that got out 2 years ago. We got one that got out a little over a year ago. So we have staff on our team, our advocacy coordinator. We have people on our team who are benefiting from the services with Hop. They were getting the fresh produce. They were getting mental health treatment because with the tailored care plans and all of that. There are people on my team right now who was able to move into an apartment, and the Healthy Opportunities Pilot was able to help them with moving into their apartment. Okay, this is how impactful it was, and I'm talking about it helped people who are now change agents working in the field, right? Healthy Opportunities Pilot was big, and it's so sad. It's so sad that when we don't have it right now, it's devastating. Especially right now, it's even more devastating because of what's going on with Snap and what had went on with Snap. And so, like, What I would say is like there was also a lot of people who lost jobs. We have a part-time person on our team now who was working on a full-time job that like the whole company shut down whenever that happened with Hop. And so like there are people who are close to me that have been impacted. She's a single mom. You know what I'm saying? She's still working with us part-time, but Healthy Opportunities Pilot done a lot of great things in helping people with, especially like the food. That was the biggest thing that I say was with the food because everybody can't get food stamps. That's the thing that people also don't know. Like there are certain drug charges that indefinitely disqualify people from getting food stamps, man. And Healthy Opportunities Pilot was able to help them. We miss Hop, and I wish Hop would come back because I mean we need it more than ever right now. Because especially in Asheville, because when you look at Hurricane Helene, man, and the impact it had on people, and I'm gonna keep talking about mental health, bro. Like there are people now, like yeah, there are some places that's done started rebuilding and building back better in the economic development space, this, that, and the third. But what about mental health, fam? You know what I'm saying? And so Healthy Opportunities Pilot was instrumental in getting people connected to services with that. Because whenever we got them connected to HOP, they got connected to the what was the Taylor Care plans, and people was getting hooked up.
Absolutely, and it's amazing how much all of these different things are connected, especially when you can think about it in terms of something like Hurricane Helene.
Yeah,
This single point in time that does shed light on all of the above: food access, behavioral health needs, mental health needs,
yeah,
access to primary care, and then how folks like formerly incarcerated people or anybody who fits
yeah,
into any of the different marginalized populations already start with less access.
yeah.
Once you have a disaster like that, you really do see just how much that lack of access means. So looking forward, I want to just ask one more question about what you see happening on the horizon. There's definitely been progress made in recent years. There's also challenges that have come up, especially recently, in this line of work. But as you look forward, I'm sure you have a laundry list of changes that are yet to be made. What are some things, either policy changes, programs that need to be launched, or efforts that need to be funded that are at the top of your priority list?
So in the reentry space, I'm very excited right now about something that that could potentially happen if we was to get this grant. So let's talk about the residential reentry program that I was telling you about earlier, right? So having a residential reentry program, a 120-day reentry program is what I would like to see. It be 120 days that people can transition there out of prison to come and get their life together, then transition out like along in a continuum to move into a halfway house after that, right? I would like to see that happen. I know the Department of Adult Corrections has contracts with certain vendors throughout the state to provide what they call transitional housing. Okay, this is something that exists. I don't know how much funding they got totally, but I know that it's something that exists because we get referrals from one of the partners right now, first at Blue Ridge, which is where our partners are at out in Black Mountain. And we have a great partnership with them and get referrals from them. And they have a contract for transitional housing with the Department of Adult Correction. We need more of those. We need more of those. We need more money going into that because that is a tactic that will decrease recidivism because it is able to address the whole person because they don't have to hurry up and go to work to pay to live there. They can actually have a reintegration into society. So that's one. And I do want to say I'm super optimistic about the MacArthur Foundation funded a planning grant here in Buncombe County, and it was headed up by an organization called Thrive Asheville. And so we partner strongly with Thrive Asheville on this planning grant, and we've been putting on focus groups that are speaking to what's missing for those who are formerly incarcerated as it relates to housing. And so we've done a significant amount of focus groups. We got a focus group tonight. This is the last one. And so what we do is we interview people who done got out of prison, not on post release, now living and working in Buncombe County, and asking them like what was needed for you coming out of prison, what types of supports are needed for people coming out of prison, what type of housing is needed for people coming out of prison, what did you need, right? And we're doing all of these focus groups, and we're gathering all of this information to then in turn have our county apply for a implementation grant from the MacArthur Foundation, which could be up to $5 million. And I have reason to believe that that would be the perfect opportunity for Operation Gateway to implement a residential reentry program.
Absolutely. So before we close it out, one last question I always like to ask is there anything else that's on your mind that you think is important that we have not talked about today?
As a reverend, I'll say that I would like to see more churches who have unused real estate. There's a significant amount of real estate that belong to churches. I would like to see more churches utilizing and repurposing their real estate to provide services for the least of these, for people coming out of prison, for people coming out of long-term treatment, recovery treatment. I'd like to see us start having more conversations with faith leaders, like intentionally, and see where are the resources that can help with repurposing it. Because I know there's a significant amount of churches that are just sitting. Congregations are just starting to get smaller and smaller and smaller. Meanwhile, we're talking about a need for real estate to provide services to help people get their lives together. So I believe that with the right voices at the table, with the right leadership, we will be able to recruit some churches that will be willing to be good stewards of their property and repurpose it for the needs of those who will turn their lives around.
Great. Well, Philip Cooper, thank you so much for taking the time to talk with us for the North Carolina Medical Journal. We really appreciate your time.